Hello, everyone. What a great crowd. I'm glad you all could join us today. My name is Karen Housknecht. I'm a professor in the Department of Biomedical Sciences and the Associate Provost for Research. And I'm really delighted to be able to introduce our seminar speaker today. Dr. Leslie Ochs is Associate Professor and Vice Chair of the Department of Pharmacy Practice in our College of Pharmacy up on the Portland campus. Leslie received her training for her master's in public health and her PhD in public health from the University of South Carolina. She then went on to get her PharmD training at Shenandoah University. And before joining UNE back in 2011, she gained a lot of clinical experience working in the VA healthcare system, working on medication management, working with veterans, with pain management, and opioid medications. Leslie is an outstanding educator, and in addition to the coursework that she teaches in the College of Pharmacy, she's very active in IPE and IPP at UNE. Some of you are CUP scholars, and you might know Dr. Ochs. She's been nominated and received many awards. She has been recognized by pharmacy students. In 2016 and 2017, she was voted Mentor of the Year by those classes, and she was also voted Most Influential Professor by the College of Pharmacy class of 2016. So she's a bit of a rock star. Leslie's research interest is in the area of pharmacoepidemiology and health outcomes. And today she's going to share with us a perspective on the opioid crisis, which we all think and talk a lot about, the role of the pharmacist in managing opioid medications, use and misuse, and also some of her most recent research publications in the area. So please join me in welcoming Dr. Leslie Ochs.
Hi. So, let me see here. Can we mute this microphone?
It's off?
Is it off?
Yeah.
Okay, great. Thank you. Fantastic. Thank you. Hi, everybody. My name is Leslie Ochs. Thank you so much for that generous introduction, Dr. Housknecht. I really appreciate it. Really happy to be with you all today. And talk to you about the opioid epidemic and our role as a pharmacist. In terms of thinking about this talk, I think one of the challenges for me was how was I going to talk about this large topic in approximately 45 minutes? Let me just start by saying that any one of the things that I'm talking about today and the information I'm sharing with you today deserves its own semester, let alone its own 75-minute lecture. So just kind of bear with me as I'm kind of moving through these topics. My plan today is to hit those highlights, to give you a sense of the role of the pharmacist. And also, I'm going to be trying to interweave some of the research that I've been doing along the way, but really trying to give you a sense of what our roles are in terms of not just clinicians, but also as researchers as well. So what we're going to do first is we're going to talk about the current opioid epidemic in the United States and look at those trends. And I think that's really important because, first of all, even though we know a lot about the opioid epidemic, it's continually evolving, I feel like, and shifting and changing pretty quickly. So we're going to look at the United States trends, but also Maine as well. I also wanted to take just a few minutes to talk about the history of opioid use and how we even got to the point of where we are today with this epidemic. Also talk about those approaches to resolving the epidemic, also thinking about those related harms and how they're tied to two drivers. We're going to talk about those two drivers that are important in terms of the opioid epidemic. Looking at opioid prescribing and then also the lack of addiction treatment and substance abuse care. We're also going to be talking about the role of the pharmacist, and we're also going to be talking about those additional approaches and opportunities for interprofessional, interdisciplinary teams to address this problem. So we're going to go ahead and just dive right in and look at some of these trends. Again, I'm going to move through some of these slides fairly quickly because some of these don't need a lot of explanation, and I'm sure that you're already aware of a lot of this information. So if we're looking nationwide at the opioid epidemic, in 2015, drug overdoses accounted for 52,404 overdose deaths, and nearly 65% of those deaths were involved in had involvement of an opioid prescription. But keep in mind that it's not also just the opioid prescriptions, but it's also our concern with heroin and fentanyl laced drugs and those derivatives as well. You can see here by this screen that drug overdoses surpassed car accidents, violence, and even HIV. So within the last year, the Portland Press Herald did a series in the newspaper, and it was called The Lost Findings, and it was a 10-piece series where they really focused on the opioid epidemic here in Maine and the deaths, and how they've been rising faster in Maine than almost every other state. Now, if we look at between the years of 2013 and 2014, we see that Maine had the third highest increase in drug-related deaths of any state. And between 2014 and 2015, Maine was again among the top states for increases. And so when I'm talking about the top, some of the top states, I'm talking only like third or fourth behind other states like New Hampshire, West Virginia, those states. So please keep that in mind. Okay. I want to just take a look here, have you take a look here at the rate of opioid-related overdose deaths in Maine. Maine, again, is one of those top 10 states with the highest rates of opioid-related overdose deaths. And really where I want you to focus is to look at the years 2014 and 2016. And here what you see is that you see that the rate of opioid-related overdose deaths doubled. And that's really, really important. We're looking at those deaths, and they were adjusted for age per 100,000 persons, with the gray line being the United States rate for opioid-related overdose, and the red line being that for Maine. So you see that we're even higher based on this chart than the overall national rate. Now, I think this is a pretty interesting slide, and the reason I wanted to bring this up, this actually looks at Maine and the death rates from opioid overdoses by county. And I think one of the things that's really interesting here, I'm going to use the pointer, I think. Yeah, here we go. You're seeing some of the highest rates right here. This is 63.6 deaths per 100,000 residents. This is in Washington County. I don't know if you've heard a lot about Washington County, but Dr. House-Connect and I had, in the last 5 years, we had been doing some work in Washington County surrounded around cultural competencies and learning about cultural competency and how to teach that topic, but also doing some work in that community. And I think one of the things that's really important as we live here in Maine is that a lot of times when I'm certainly not a local, if you haven't heard it, I'm from the South, but I've been here for 8 years, and I feel like I've been in the ocean long enough without a wetsuit that I could potentially be a local. But anyway, the thing that's interesting is that when folks come to Maine, we think of the summer, we think of the people who are coming to visit, and the people who have a lot of money. We see these houses on the coast, right? But the reality is that some of the counties here in Maine are amongst some of the poorest counties in the United States, right? And Washington County is one of them. Please also notice we're going to be talking a little bit more about these counties as well. Here, this is Kennebec and Somerset. And these two counties right here are really important as we talk about the opioid addiction as well. Here where the rates are 34.5 per 100,000 residents is Androscoggin. This is us right here in York County. Right above Washington County there is Penobscot County, and then the 29.7 rate is Aroostook. So you see that we've really got some problems, if you will, northeast and west, right? And that's going to be important to us as we continue to talk about this topic. Again, if you look at those opioid-related overdose deaths in Maine in terms of the types of medications that people are dying from, you'll see that since 2012, the number of deaths attributed to heroin overdoses increased from 12 to 55 in 2016. And that's a more than fourfold increase. So if you look at just the pure numbers, you might think, oh, that's not that big of a problem. Those numbers are pretty small. But once you start to think about how much of an increase that is, and we're actually seeing these same trends nationally as well, right? We've seen that the synthetic opioid-related deaths, overdose deaths, have increased dramatically from 19 to nearly 20 deaths in that same time period. And even though we have overdose deaths that are related to prescription opioids, like those medications like Percocet or Vicodin or oxycodone, short-acting and long-acting, we see that these deaths due to these types of medications have been increasing, but certainly not at the same rate. Okay, so really, here's what it comes down to if we look at the trends over time and we think about opioid prescribing. The amount of opioids prescribed per person was 3 times higher in 2015 than it was in 1998. A lot of times you will see that when we're talking about opioids and opioid prescriptions, instead of measuring it by the number of prescriptions, we'll actually measure it by morphine milligram equivalents. And that's important because that's the standard that we use, as you all probably know, so that we can talk about, even though we may be talking about different types of drugs that have different potencies, we can kind of standardize the dosing and think about the amount of morphine that a patient may be receiving per day. So in 1998, in the US, it was 180 morphine milliequivalents per day. In 2015, it was 640 morphine milligrams per day. And so you think to yourself, okay, so what does that mean? So really, this is what it comes down to. That 640 morphine milligrams equivalents is if everybody in the country received a prescription for oxycodone, 5 milligrams, immediate release, every 4 hours, around the clock, for 3 weeks. That's a lot of medication. That's a lot of medication. And what we're going to see is that we see across the country and in Maine, specifically within certain counties, we have rates even higher than that, okay? I just want to draw your attention here to looking at the morphine milligram equivalents of opioids prescribed per capita for 2015. And you know, here we are right in Maine, okay? And here are these counties again that we're talking about, right? We're talking about Androscoggin, we're talking about Kennebec and Somerset here, right? And their range is based on this map, is 957 morphine milliequivalents to 5,543 morphine milliequivalents, okay? Now, I guess the good news is that for our counties, they're not that high toward that range. However, for Kennebec County, the morphine milligram equivalent for opioid prescription per day was 1,691 morphine milligram equivalents, okay? Somerset and Pocahontas were also within that 1,000 morphine milligram equivalent range. So again, we've got some issues here in terms of the counties, but if you look at the United States as a whole, there are a lot darker shaded areas which indicate that there are higher morphine milligram equivalents of opioids prescribed across the country. So if we look at the opioid prescribing, we actually are seeing some declining, where the number of those prescriptions had declined by almost 22% in Maine from 2013 to 2016. We literally went from 1 million prescriptions down to 880,000 prescriptions. And that was the 4th steepest drop in the country. Overall, nationally, the opioid prescriptions have gone down about 15%. So there are some shifts that are happening, right? Again, if you look at this map by county, here we see again Kennebec County, Somerset County, as some of those counties where actually there were not decreases in terms of prescription volume. Actually, Kennebunk County went up about 35%, and Somerset County prescribing for opioids went up nearly 25%. That amount of prescriptions here for Kennebunk was nearly 3 to 4 times more opioid prescribing than we saw in Lincoln or Cumberland County here. Okay? So the other thing I just want to draw your attention to as we continue to talk is we see Washington County here in terms of the change in prescription volume from 2010 to 2015. And so it looks like they're doing pretty good. However, we also have to think about those deaths that are related to heroin and fentanyl. And in that part of the state, I dare say, I've talked to a couple of pharmacists over the last couple of days, and they say they're using language like ravaged. It's a pretty big problem, and it's really overwhelming. Again, I'm just kind of sharing this information so that you can see some of these trends. You can see the number of overdose deaths that have been happening in 2016. There was an increase of 40% compared to that same time period in 2015. And in 2017, there were 418 overdose deaths. And the most important thing here to remember is that the illicit opioid use is increasing. And I'm talking here about those opioids that are laced, that heroin and opioids that are laced with sufentanil and carfentanil. Just to kind of show you a picture here in terms of the heroin and the fentanyl and carfentanil, this is just to give you an idea, not really of the potency, but to look to see how much heroin you would have to get, and how much to have a certain amount of effect compared to fentanyl, compared to the carfentanil. And so as you see, you can see how potent and strong these medications are. You can also see why we're probably seeing a lot of this fentanyl and carfentanil now being laced in some of these medications, right? Because if this heroin is being shipped from Mexico, it's a lot cheaper to get the fentanyl and the carfentanil supply to the United States, right? So they're not having to pay for all that shipment. Plus, they're able to make some of the fentanyl and carfentanil in some of these home-based labs, if you will. So here's another, one more graph just to kind of hit the point home if we need one more graph, which I'm not sure that we really do. But again, we're looking here at the drugs that were involved in the U.S. overdose deaths from 2000 to 2016. And you can see that the deaths due to fentanyl and those fentanyl analogs have surpassed not only heroin, but prescription opioids, also cocaine, methamphetamine, and methadone as well. So, you know, I think this kind of really dovetails nicely into the next part of what we're going to be talking about. So this is really why it's so important for us as not just pharmacists, but as healthcare providers, that we are actually able to provide those evidence-based interventions, but that we also get the training that we need in the classroom, in the school, before we go out to the clinical rounds. And we think that that's really important so that we're also prepared for this as well, for these problems as well. So let's take a quick look at the history of opioid use in the United States. Really, if you look at it, and we're going to look at over the last 100 years or so, the current opioid addiction crisis is really a replay of history. America's first epidemic of opioid addiction occurred in the second half of the 19th century. And here you see in the 1840s, there were about 0.72 addicted persons per 1,000 persons there in the 1840s. In the 1860s, morphine became more widespread, and it was actually, there were lots of different people who were using morphine, and what I mean by that is that not only was it readily available, but we had mothers dosing themselves. They were also dosing their children using opium tinctures for medications and to help themselves and their children feel better. They used opioids to alleviate hangovers, and then also there was a big underground in terms of the Chinese immigrants that were smoking opium, and then the underground opioid or opium dens that moved from Chinese immigrants to the white population during that time. We also had the Civil War between 1861 and 1865, where we also saw widespread use of morphine, not only during the war, and believe me, morphine, when you're in a lot of pain, it is a fantastic medication, and it's a needed medication. They were using it a lot at wartime, but they were also using it for the soldiers when they came home, not only for their painful injuries, but also for diarrhea as well. So that by the time the 1890s moved near, the supply supported 4.59 addicted individuals per 1,000 people, and that was nearly a 538% increase at that time. Also during the 1890s, we saw a lot of IV heroin use at that time. And in 1898, heroin, it was commercially available, and it was termed as the wonder drug. Then in the 1920s, we saw a drop in terms of people who were addicted per 1,000 persons, and this was due to the 1920s, where we saw the risk of addiction was established. So now you had your medical professionals who were looking for addiction and trying to figure out how they could help individuals with their addiction. But we also had the Harrison Narcotics Tax Act. And in this act, there was taxing on those folks who were making, importing, or selling any derivative of opium or cocoa leaves. We also had in 1924, heroin became illegal. Between the 1920s and the 1960s, there was a transient increase in heroin use, and really what we were seeing during that time is the effect in the inner city population. This really happened also during World War II, where we were having a lot of folks that were moving into the inner cities, but also out of the inner cities and out into more country or urban areas that surrounded the big cities. So we saw a lot of inner city use during that time. 1970, we saw Vicodin and Percocet hit the U.S. market. In 1980, it was followed by a letter from the New England Journal of Medicine, where they stated that addiction was rare. In 1986, this was probably one of the pivotal papers that really helped to kind of get things moving as we think about the history of opioid use and the increase of use of these medications. There was a paper that came out describing the treatment of 38 chronic pain patients. And in their care of these patients, they found that long-acting opioid was safe and it could be used on a long-term basis. In the 1990s, pain became the fifth vital. Prior to the 1990s, when you were in the hospital or you went to get care from your doctor, you really didn't measure pain very much at all. But in the 1990s, there was a real push that pain needed to be a fifth vital. And that became really important as we're thinking about that. And one of the reasons that became important is because you had all of these pain groups. You also had the Joint Commission who accredits hospitals, and the accreditation of hospitals is connected to reimbursement for the care that is provided for folks, and they were all supporting this fifth vital sign. Right? So they were also trying to also measure how well we were doing on these the fifth vital sign, the pain, by also conducting and using surveys when you were receiving care. Were folks doing enough to control your pain? So we really did need to have that piece in place, but it was almost a perfect storm, if you will, that all of these things kind of started to happen. And we certainly saw a lot more use of the pain medications. 1995 was the approval of OxyContin. 1996 to 2001 is when the marketing campaign began. And in 1996 alone, there were 20,000 educational programs on OxyContin. Again, Joint Commission in 2001 requires pain assessment in all those patients like I mentioned. 2007, Purdue Pharma was then charged with misbranding because what they had done is they basically said that these long-acting medications are not addictive, right? Which honestly, I was a pharmacist in the late 1980s. And when all of this was happening with OxyContin, I was asked to do a continuing education, and I couldn't figure out the mechanism of action because I'm like, it's acting at the same receptor, but everybody's saying it's not addictive. How does that happen? So honestly, I never did any education because I was within a system. I was in the VA at that point where we were seeing increased uses of these medications, and honestly, it just didn't make sense to me in terms of what was being marketed. But nonetheless, it got marketed. Purdue Pharma got charged with the misbranding because of all of their materials that said it was not addictive and it could be used without any harm. And then 2010, we had the abuse deterrent OxyContin comes on the market, and then you know as well that although it was well-intentioned, people now were starting to use it and crush it, and that's what really helped us to transition to heroin. So that's kind of how we got to where we are now. So I know that this is kind of a busy slide, but just be patient with me here for just a minute, because I do think that this is really important, thinking about the drivers of the opioid epidemic. And these are really the two issues that we think have helped to drive this epidemic as well, where you have significant increase in the opioid prescribing between the 1990s and the early 2000s, where we are prescribing opioids for chronic pain, and we're not even sure if the opioids benefit those patients with chronic pain. We're not only prescribing those medications for chronic pain, but we're prescribing at higher doses and for longer periods of time. And then we're also prescribing those medications in combinations, and we're going to talk a little bit about that. And when I'm talking about combinations, we're talking about having patients on large doses of opioids in combination with medications, with benzodiazepines like Valium, alprazolam, muscle relaxants, like Flexeril, and now we're starting to see a lot of other combinations with other types of drugs and gabapentin. And these medications in combination with opioids increase the risk for overdose. And as a matter of fact, with gabapentin in particular, and some of the work that I'm interested in, what we're finding is if you're on an opioid and gabapentin, your risk for overdose increases by a pretty significant amount, right? So we have to be careful and be thoughtful as pharmacists, and these are some of the ways in which we're going to work through this, thinking about our role to help with this epidemic. And then also the lack of addiction treatment, such as the medication-assisted treatments, which includes naloxone, buprenorphine, or methadone. Most folks in the United States with opioid addictions don't receive these treatments, and a lot of that is due to lack of access, right? And there are a lot of folks out there, and we know that that lack of access to treatment is one of those contributors to the increased rates of heroin, fentanyl use, and injection drug use and overdose deaths. So we've really got to figure that one out, because we're doing a great job on the supply side and controlling and really working hard to work on prescribing for opioids. But now what's happening is folks are turning to other types of medications, and in many cases illicit drug use. So we've got to have the treatment on the other side as well to help with that. Otherwise, I'm afraid that the overdose deaths are going to continue to rise with heroin and fentanyl. So what is our role as pharmacists as we move through and think about this epidemic? And really, I'm going to try to move through here, not too quickly, but try to hit the highlights here so that we have enough time for questions toward the end. So just to kind of give you an overview and thinking about opioid effectiveness in terms of the evidence and what's out there. The CDC really came out with their guidelines in 2016 for prescribing opioids for chronic pain. And really it was one of the first large documents that came out at that time to really give folks a lot of direction about chronic pain in terms of thinking about pain medications across different spectrums to think about prescribing for these medications. They really talked a lot about in this paper that there really, and what we know is that there's not a lot of evidence out there for long-term opioid therapy for chronic non-cancer pain. It's limited at best. They're placebo-controlled randomized trials, and in most cases they're less than 6 weeks, which is not really a lot of time. There's insufficient evidence to determine that there's even an analgesic benefit over no opioid at all. And there's a lot of evidence that the serious risks to overdose are dose dependent, right? So that paper was really important in terms of thinking about chronic pain. So we have to consider, are these medications effective when we're thinking about prescribing? But the other thing that we really have to think about too when we're prescribing, or even when we're thinking about being with our patients, because as pharmacists we're not prescribing these medications, but we're seeing these patients firsthand, is we also have to really think about the impact of childhood trauma. And the impact of that trauma in terms of substance use disorder and chronic pain. And as you see here, all these childhood experiences, they're called adverse childhood experiences here, but actually there is a screening tool, if you will. It's called the ACE tool, where healthcare teams can really measure childhood trauma. And if the thought is that those children who have adverse childhood experiences lead to the adoption of more health risky behaviors, disease and disability, and also social, emotional, and cognitive impairment. And all of those things can lead to opioid use or opioid overuse, if you will. Those children with ACE scores greater than or equal to 4 are associated with an increased risk of substance use disorder, depression, and chronic pain. So even if they don't have these things, if their score is greater than or equal to 4, and each one of these experiences counts as 1 point on the scale, they total up all those points to get the score. So I think that as we're also thinking about treatment, right, medication-assisted treatment, we also have to keep thinking that there's this underlying piece that we really don't talk about very much, which is mental health, right? And in a lot of instances, when we're thinking about substance use disorder, opioid use disorder, and opioid overdose and these deaths, we have to always think about those traumas that may have preceded and led to the point that we are with our patients. So really, the CDC, getting back to the CDC opioid guidelines, there were really 3 sections of this guideline, and this was really important in terms of determining when to initiate and continue those opioids for chronic pain. And this was really important, not only just selecting the types of medications, but also considering other therapies as well that were non-pharmacologic therapies. Trying to think about those treatment goals and then speaking with our patients about the risk and benefits of these medications. And as a pharmacist, do patients even want to receive these medications, right? Do they even have an intention, right? Just a quick story. I had an outpatient surgery procedure, and I had no intention of going on a pain medication. I thought, well, because of the good pharmacist I am, I'm thinking, I'll just do Motrin, right? And this is the dose that I'm thinking about. My husband, when I came out of surgery, I was resting and waiting to go home. My husband picked me up, took me home. I didn't know the physician had written a prescription, and she had given him a prescription for pain medications. He comes to my bed and says, honey, your pain medications are here. And I see the pain medication. I'm like, oh, this looks like oxycodone. I'm not going to take this. How many did they give me? 10? 100. Right? 100. I had no intention of using it. So again, as healthcare providers, you know, when do we have conversations with our patients about what we want to use? Right? When do we talk to our patients about things, you know, how to use these medications that are more than just, hey, you better watch out for that medication, close your purse because somebody's going to steal it, right? You think I'm making this up. I mean, it's out there. Now, this is not to say these are bad providers. Please don't mistake me. These are all the things that have contributed to help us get here. So, you know, and the thing for me in terms of the VA, what was interesting is it's not only the types of medications that we're selecting, but how long do we want our patients to be on these medications, right? In the VA 20 years ago, everybody got 30 tablets of Vicodin. You had a toothache, 30 Vicodin. You had a cough, 30 Vicodin, right? There's not a problem with 30 Vicodin, except that when you run out of that Vicodin and then you go to the ER because you still have pain and nobody knows where the pain's coming from, so they give you 30 more Vicodin, and they do that for 20 years. That's a problem, right? So the other thing that I'm really interested in is acute pain, right? And how many days supply do we give patients, right? When do patients transition from acute pain to chronic pain? Does it matter how many days supply of these medications you get? And the CDC guidelines here, even though they were talking about chronic pain, there's a big debate about how do we define chronic pain. And if you want to be completely confused, look at the state law for Maine for prescribing for opioids. The acute and chronic pain definitions are literally the same. So, you could get a prescription from a patient, and a pharmacist, I could, look at the prescription, and the practice says, oh, it's for acute pain. And then the week later, it's coming back for chronic pain, right? Now, I don't blame the providers because they're just trying to get their patients the best care, and they're trying to be helpful to them. But that's what I'm saying. We have to think about those things. We also have to think about the duration is a big thing. We also have to think about the dose and how are we going to follow up. So are we going to give somebody 100 oxycodone for an outpatient procedure? Are we going to follow up? Are we going to talk to them? Hey, how's it going? Or is it going to be discontinued, right? We also have to assess risk and those harms of opioid use. Right? And there are lots of different ways that we can do that. And looking again at those co-prescribing of those medications and using prescription drug monitoring programs, right? So you're going to see some really consistent themes all the way through here. And I'm just going to kind of go through some of these algorithms, if you will. This is for acute pain management in terms of just really thinking about, as a pharmacist, what we would do. This is coming from one of our therapeutics books, and this algorithm is pretty useful and a lot of folks will look at. But we use this to kind of help us think about acute pain management in terms of what's the score of the pain, right? Is it mild pain? Is it moderate pain or severe pain based on those scales? How is it measured? And for how long? And determining on the type of pain, then that may also determine what type of medication that you're going to be receiving, right? And is it possible to be using acetaminophen and nonsteroidal anti-inflammatories like Motrin, ibuprofen, naproxen, those types of medications, right? And a lot of those medications you can get over the counter, unless, of course, there's a certain strength, and then you may have to have a prescription. But then that's also where your pharmacist comes into play because they can help you with your patients with that dosing, right? But also, even with acute pain, it's not just about can we start with acetaminophen and nonsteroidal anti-inflammatory medications first. If it's more severe pain, then can we do nonsteroidal in combination with opioids, or do we need to have an opioid for that severe pain? And if so, then we really have to think about how long that is, okay? Chronic pain, again, we're looking at those 3 different levels of pain, but now we're looking at different types of medications besides just your acetaminophen, Tylenol, your nonsteroidal anti-inflammatory medications. Now we're also starting to think about those other types of medications or adjuvant treatments, like pulling in antidepressants, right? Like amitriptyline or Elavil, venlafaxine. We're also maybe considering on some level some of those medications that were first brought to market as anticonvulsants like gabapentin or pregabalin. Those are also other good choices. And what you're going to see now, which is a shift really, is that providers are trying to do such a great job that they're really looking at those other options for pain management. But where we come in as pharmacists is we really have to manage those, the milligram dosing per day, because what's happening is folks are moving to these medications like gabapentin, which is really fantastic. But really what a lot of folks don't know is that with gabapentin, really the maximum dose, you can go as high as 3,600 milligrams per day, so that would be 600 milligrams 4 times a day. But really, if you look at the evidence, 1,800 milligrams is where you see your maximum benefit. So anything more than that, you're just giving drug and increasing risk. Sedation, and if you're in combination with an opioid, then that's a problem, right? And so what we're seeing in some of our claims data, insurance claims data, we're seeing doses. It was hard to believe. I thought it was like a mix-up in the data, right? We're looking at insurance data, claims data, national claims data, and doses as high as 8,000, 9,000, 10,000 milligrams a day. folks, that's hard to believe. I thought there was a problem with the data, but we had a couple of people look at it, and it's true. So just be mindful of that, how a pharmacist can help. In terms of opioid prescribing here, we are writing for fewer prescriptions now. We're seeing that in the practice. We always have the opportunity to call our providers to make recommendations for acetaminophen, ibuprofen, and naproxen, but also that there are those non-pharmacologic therapies that are important too, in terms of like physical therapy, right? Exercise is also important in terms of pain therapy, acupuncture, biofeedback. There are lots of ways to treat pain. Again, fewer day supply is important, and those lower dosing. Just quickly, and a shout out to all of my colleagues who are practicing in geriatrics and in the elderly population, that these medications, we have to be very careful when we're dosing these medications in the elderly population, because some of the same things that we're talking about as a whole, we also have to think about the elderly population as well. And if you see these risks here, these are not just risks to be seen in the elderly population. These are all risks. These are risks that we can all experience and that we have to be mindful of. Prescribing these medications and reviewing these medications as a pharmacist, I'm looking for those patients who may have some type of respiratory condition that may put them at a higher risk for respiratory depression. I'm looking for drug-drug interactions. Holy smokes. There is a ton of drug-drug interactions, right? Drug-drug or drug disease interactions, those patients with congestive heart failure, cardiac issues. If you're on methadone, one of the problems with methadone is the QTC intervals, right? And if you're on it for long periods of time, right, and at high doses, and you've already got heart issues, as we would say in the South, honey, hush. We do not want those folks on those medications, right? Chronic liver and kidney disease, we have to be really mindful as pharmacists because these medications are renally cleared and cleared by the liver. So we're always having to adjust these doses, right? Then age-related adverse effects due to the clearance of the patient, their age, that type of thing, and then fall of risk, right? I don't know about you, but when I'm taking these strong pain medications, I can get dizzy, especially if you get up too quickly, right? So you have to be really careful with this. So in terms of thinking about the opioid prescription or prescribing, and so we're already thinking, again, remember, we're thinking about the types of medications, how long we're going to be prescribing, and the dose, which leads us to tapering, and this is really important. And let me tell you why tapering is really important. And as pharmacists, we can help, right? If you're looking at high-dose opioids and overdose risk, right? Morphine milligram equivalents per day. If you look at this graph, you can see that once you start to go above 50 morphine milliequivalents per day of morphine, your risk for overdose due to opioid use, it skyrockets, right? Especially for those patients who are receiving more than 100 milligrams per day, or 100 milligrams per day. So why is that so important? Look at these numbers in 2014 in May. Look how many people we had who were receiving at least 100 morphine milligram equivalents per day. 16,000 patients and 1,200 patients were receiving more than 300 morphine milliequivalents per day, right? So back in January 2017, to help with this, the Maine state law shifted that said that everybody's daily supply had to be shifted to 100 morphine milliequivalents per day. But let's just get one thing straight. Right? That's not per prescription. That's an aggregated total. So if you've got a patient who's on 3 opioid medications, that's for a total of 100 morphine milligram equivalents. And what we're seeing and what I'm hearing from my colleagues in the community is there's a lot of confusion about that, right? So that's really important. And we've been working really hard to help to get those, to meet those limits for the state law. There's a lot of things that we have to consider if we're going to be helping to get patients to those to that goal of 100 morphine milligram equivalents. And some of the things that we may have to think about in terms of switching a patient from one opioid to another, if it's because they're being discharged from the hospital to home, if they're going from oral to IV, we may be using the morphine equivalent dose calculator, and this is the Washington State Agency Medical Director's calculator. And if there's one thing that you take away from this, I hope there are lots of things, but if there's one thing to take away, this is the calculator. Right? We have to be really mindful here because this calculator, it calculates nonlinear dosing for methadone. And that's really, really important because not all the other calculators do, right? Which basically means it doesn't have the methadone conversion. But when we think about nonlinear kinetics, what does that really mean? It means that, you know, if you have something that's linear, if you increase the dose of the medication, you would expect to see an increase in the effects and the concentration. Methadone does not work that way. So start it. Remember, never forget. It's really important, right? Also in this calculator, they have morphine milligram equivalent tables. Here it will tell you how many, the type of medication and the milligram strength and what it is equal to 100 morphine milligram equivalents here. The other thing that you will could rely on your pharmacist for is opioid dose conversion calculations, right? You don't have to do this yourself. We can help, and actually we're quite good at this. But actually you're going to be calculating those number of doses per day, then looking at the total daily dose, converting it from maybe an IV to a PO, right? And if you look at this top table right here, you see this is actually a potency table. So you'll see how many, what's the ratio going from IV or parenteral to PO, right? Then depending on where the patient is in terms of their therapy, if they're well controlled, once you convert that current opioid to the desired opioid, you may want to decrease that total daily dose by 25%, and divide the number of doses per day, and then typically we would round that down. Here's another resource in Lexicomp, calculating equianalgesic doses, which again is also another source that may be helpful to you in terms of, and it's helpful to us in terms of calculating those doses. And then also, how do we taper those patients? And this comes from a taper plan from one of our colleagues at the College of Pharmacy, Dr. Jessica Bates, who's a clinical pharmacist and a clinical faculty at Penobscot Community Health Center. And actually, if you look at this taper schedule here, this is what we would use to help our patients go from those higher morphine milligram equivalent doses down to meet the 100. Where we would start with a 10% reduction every week or every other week. And then if we needed to do a more rapid taper, then we would go to 10 to 20% every week. And then slowing the taper when a patient gets to 10 to 20% of the starting daily dose. The big thing you have to watch out for is the side effects of tapering. Remember, you're weaning them off opioids, so you're going to expect some of that as well. Again, compassionate opioid tapering, they talk a lot about this at Penobscot. Keep in mind the patient did not prescribe the opioids to themselves. So someone told them that they needed this, right? Pain can be a really scary thing. I don't know if you have friends or family members or if you've experienced a lot. It can be really just awful, painful, devastating. And it's scary if you're telling a patient that you're going to start to wean them off their doses that have helped them with their pain. So just be mindful that these can be difficult conversations, and how do you want to talk about those medications. For time's sake, I want to move through these things fairly quickly here. The other way that we would look at medications as a pharmacist is through the prescription drug monitoring program. And this is a tool to help us, that we can use to help us think about those patients, look at their opioid prescriptions. And as a pharmacist, every time somebody came into our pharmacy, we would want to go through this, use the PDMP, because we're really trying to make sure that they're not on multiple pain medications. We're also trying to make sure that that there's no diversion going on or multiple providers, because we don't all go to the same provider every time. So we may be getting care in multiple places. Also see that there's some what we call threshold reports that are really important as additional information that your pharmacist can run. If you're a provider, when you become a provider, you will actually be assigned access to have the PDMP. So you will also have these threshold reports too, and you can use these reports to tell you how your patients are doing. And quite frequently as pharmacists, we would run these reports and then go back to the team and say, hey, we need to think about, looking at the amount of Tylenol that someone's on, looking at someone who's on those multiple, we've got a patient who's on an opioid and Xanax, and we really need to think about taking them off these medications. And also, or calculating the morphine milligram equivalents. So this is great information. You see here the data that's collected here from PDMP. As a researcher, I would be very interested in also looking at these data and trying to understand those prescription or those prescribing trends for opioids. Okay. Again, as a licensed prescriber, which you're definitely going to be doing, you're going to be required to check the data or check the PDMP every time you write that first prescription for an opioid or a benzodiazepine if you're here in Maine, and then check every 90 days after. As a pharmacist, as good practice, we would want to check every time anyway, but really we're only responsible to check those prescriptions for non-residents, any prescriptions that are written for out-of-state providers, or if someone's paying for cash. Let me just make a quick note about screening. Again, screening, I cannot put an emphasis on screening. And here's the reality. There have been instances in which I have used screening tools, or I either work with team members, nurses, social workers, who may be doing some of these screens. I just want to make a quick plug for SBIRT, which is the Screening Brief Intervention and Referral to Treatment tool. It takes place before serious health consequences occur. It's very easy. There are 3 components core components to this screening, where you actually conduct a brief intervention if the patient is at high risk for certain issues, then they may receive treatment or be referred to treatment, okay? Really, the goal of SBIRT is to screen and assess readiness for change with our patients, and to assist those folks who may be working to change those risky behaviors. So there are initial questions that you would want to ask. How often do you drink? How many drinks do you take per day? Have you had more than 4 or more drinks? And then you would ask similar questions as it relates to prescription use. So you can see that there's a way to kind of get at the risk of substance use here, right? And then based on that determination, if your patient is at high risk, then you may refer them on. Really, the big thing that's really important here is that you don't have to be a drug and alcohol specialist, and it's quick and easy, and it's a way that you can actually plug it right into your practice. We have done that. I have done that in my practice as well. It takes just a few minutes, right? But you're really getting a sense of what's going on with your patients. Narcan, I'm just going to say something quickly about Narcan, harm reduction, right? It reverses opioid overdose greater than 90% of the time, so why would we not want our patients to have this? Right? Again, you have to be really mindful. It comes in, you have to be mindful for those folks The side effects afterwards, once patient takes the Narcan, because remember the Narcan is a reversal agent, right? It comes in a nasal spray and an injection and an auto-injector. And really what's happening here in Maine is that there's a draft proposal where pharmacists will be able to dispense and prescribe Narcan, right? Now, there are some drugstores that are already in place, have some agreements in place like Walgreens. I was talking to one of my colleagues, Heather Stewart, who works in Portland. She can actually work under the collaborative drug therapy management agreement under a physician, and she can actually prescribe and dispense Narcan. But we're still trying to work on that here in Maine, right? Under her agreement with the physician that she's practicing with at Walgreens, you can see here anybody can request this medication, and then there are certain patients that as pharmacists we would consider as at risk, and we would probably more than likely want to dispense Narcan. The thing that I talked to Heather about that's really interesting is that they've actually started to counsel on Narcan for every opioid prescription and giving patients the option to have the Narcan. Let me tell you, there's nothing scarier in the world than to see somebody die from an overdose and you can't do a darn thing about it. It's awful. You know what they need, and it's just, it's not there. So please help your colleagues, I mean all your healthcare colleagues, to make sure that this is becomes something really important for our patients. We know it works, and you know, honest to goodness, if your family member had breast cancer and we could get a treatment to that family member to cure breast cancer, same thing here with Narcan. We can save lives. MAT, again, medications for addiction treatment. This is for opioid use disorder, pharmacotherapy treatment, and then I put dash gaps. Just take a look at that map there, right? The light gray, I mean the spotted areas there on their map, these are the substance use disorder facilities that offer all three forms of pharmacotherapy at their treatment centers, right? Buprenorphine, methadone, and naltrexone. And Maine is completely that light gray, and you can't really see that color, but it's less than 1, right? I'm not going to read off the statistics, but again, we need treatment for these patients. We know that alternatives are ineffective. When I'm talking about alternatives, I mean drug prevention programs and drug-related incarceration. I mean, we know that doesn't work. I was on some really big federal funded evaluation programs for the DARE program, increasing knowledge, you know, awareness, those types of things. They're not effective, right? MAT has shown it's beneficial and it's cost effective, but it's underutilized, and we as pharmacists can help access to MAT. So of course there are lots of other roles as pharmacists that we're very active with in our communities, educating the public, patients, providers. Also community medication disposal events like medication take-back are equally important. Let me tell you, if you guys are looking for an experience and you want to know how much opioids and opioid prescriptions are in your community, come to the College of Pharmacy in October and work with us, and we would love to have you. And Heather Stewart works with us very closely as well. It's unbelievable. 70% of opioid prescriptions that are prescribed, now this is in a study that I worked with with Dr. Stewart and a couple of other colleagues. We thought, our first study was in Maine, 75% of those prescriptions come back unused. So if you have 100 oxycodone, you'll use 25 and 75 you're returning as not used. We thought it was just Maine. Everybody kept saying, oh, it's just Maine. Guess what, folks? It's not just Maine. When we looked at Texas, Florida, Ohio, Kentucky, we didn't see the 70% rate, but we saw 62%, right? So also, participating in healthcare organizations, I sat on a lot of advisory committees at the local Portland, at the Portland city government level and at the public health department there. Community coalitions are unbelievable. I've worked on a lot of community coalitions and also evaluating the effectiveness of community coalitions in substance abuse. Very powerful interventions. And then advocate for those policies at the state and national level, for Narcan use, for MAT access, lots of other work that's going on out there as well. And just one quick thing about teamwork. Really, SAMHSA has determined that interprofessional, interdisciplinary teams is a best practice for substance abuse and this opioid addiction issues, right? And so we're doing a lot of things here at UNE with IPE and interprofessional education and interprofessional practice, IPP. But if you will, just kind of look at this model and just, if you can bear with me for just 1 minute. So today I've talked about my roles and some of my roles and responsibilities as a pharmacist. These are really the interprofessional competencies where I'm talking to you about my roles and responsibilities, but I also am working on a team that have other roles and responsibilities as well. How do we communicate as a team together to help our patients? Do we value teamwork and coordinating care? Really, as a team, is it our responsibility to help to coordinate those services? Because goodness, we know the system. Our patients don't, right? Teamwork, working together as a team, and that all team members are leaders within that team, and we have the patient at the center. Remember, the patient definitely is the expert in terms of their care. Teamwork, I think, is really the other way that we're moving in terms of changing healthcare. So we've talked about a few things. The epidemic is changing continually. We've seen some signs of progress in terms of opioid prescribing. The pharmacist is an integral part of the team, but not only the pharmacist, we have lots of other providers, social work, DOs, doctors of osteopathic medicine. Of course, we're all going to be working together, right? Occupational therapists, physical therapists, social work folks, counselors, nurse practitioners, and PAs. Please don't. If you need anything, if there's anything we can do to help you out at the College of Pharmacy as it relates to any of this or anything that has anything to do with pharmacotherapy, please let us know. We'll be happy to work with you and look forward to seeing you guys soon. Thanks so much for your attention.
Thank you, Dr. One question. Covered a lot of ground.
Can I interrupt before? It's me, Karen, sorry. Before people leave, can I just remind everyone to sign in if you did not do so already? So now, question.
Just want to say thank you for that lovely talk. It was very informative. My question is about the algorithm flowcharts that you had presented on and all the screening tools. Are those established procedures or are they more like suggested guidelines? And if they are just guidelines, how widely used are they right now among healthcare providers?
Sure, that's a great question. The ESPERT, we actually have a group here on campus. There's a leadership team, and actually you can get a certificate in training in ESPERT. And so there's that. But in terms of the algorithms that I showed, they're actually guide us in terms of our treatment. One of the things that's been a little tricky for acute pain and chronic pain is that there are some guidelines, but they're not specific in a lot of ways. There's a lot of leeway in terms of treatment. Yeah. Sure.
Dr. Ochs, I just want to inform our first-year students, our colleagues who have not been exposed yet to ESPERT, they will be. And we have a strong thread that goes through and opportunities
Sure.
To become ESPERT leaders. So those are, the guidelines will be, you will be learning those and practicing those on your on-campus years and potentially in your clerkships.